So without further ado, I'm just delighted to welcome Dr. Nina Ma, who is the Director of Bone and Mineral Metabolism Program, Children's Hospital in Colorado. And she is going to speak to us about a disorder that is actually one of our newer members of the Rare Bone Disease Alliance, sometimes more easily done by initials, but multicentric multicentral carpotarsal osteolysis, a clinical overview and reappraisal of pathogenesis. Welcome, Dr. Ma. We're so pleased to have you with us.
Great. Well, thank you. Let me take control of the screen here. All right, that should do it. Can you see my title slide, hopefully?
Not yet, but we see you starting screen sharing. There we go.
Okay, there's a little bit of a lag with our connection here, but it sounds like you can see my title slide now.
Yes, ma'am.
Okay, wonderful. Well, good afternoon, everybody. I just wanted to start out by thanking Michael Stewart and Dr. Tosi for the kind invitation for me to join your session today. I actually have a recurring conflict on Thursday, so I haven't been able to attend this specific tele-echo series on a regular basis. And so it's truly a delight and a treat today to be able to join your live session. So as Dr. Tosi mentioned, I'll be speaking on the topic of MCTO, or multicentric carpotarsal osteolysis. And the title of my talk is a clinical overview and reappraisal of pathogenesis. This is my disclosures slide. We will be discussing a bit about off-label use of bisphosphonates and denosumab in the pediatric population. So these are my objectives. I will start out by providing a clinical overview of MCTO. We'll really highlight the key clinical aspects of the condition. We'll discuss the MAFB gene and protein function in MCTO. We'll touch on the treatments that have been used in MCTO. And we'll round out the didactic portion of the talk discussing a reappraisal of the pathogenesis in this condition. Objective number 4 will be facilitated by the presentation of a pediatric case study at the conclusion, after the conclusion of the didactic portion. So I encourage you to stick around for that case study presentation. So this is an introductory slide. It provides a 20,000-foot view of MCTO to really help people get familiar with this rather rare condition. The actual incidence and prevalence of MCTO is not known, but it is exceedingly rare. In 2012 is when Zankel and colleagues had identified MAFB as the causative gene of MCTO. And since then, which is now about a decade ago, less than 60 patients have been reported globally in the published literature. MCTO is caused by dominant missense mutations in the transactivation domain of MAFB. MCTO is characterized by aggressive osteolysis of the carpal and tarsal bones, and this is accompanied by a progressive nephropathy. The symptoms typically present very early in childhood. The reported median age of symptom onset is as young as 2 years old, with a range of 0 to 12 years. The symptoms include painful swelling of the wrists and ankles. And so these patients are frequently misdiagnosed as juvenile idiopathic arthritis, or JIA, which is a far more common condition than MCTO. Pathogenesis is not well understood, but we will get into a deeper discussion about this bullet point throughout the presentation. Current treatment options are rather limited. Anti-resorptive agents have been the most commonly used in this condition, and to date, they've not really been proven to be effective. So in MCTO, there is a proclivity for the carpal and tarsal bones, as the name of the condition implies. The x-rays on the left-hand side of the slide are that of a son and mother pair. The 6-year-old son was initially diagnosed with JIA and only later diagnosed with MCTO after presenting to a geneticist with joint deformities and also facial dysmorphisms. His mother, by age 33 years old, had a long-standing history of joint symptoms as well as joint deformities, and she was diagnosed with erosive arthritis in her youth. And she had also presented with craniofacial deformities. And once the son's genetic diagnosis of MCTO is made is only after which she was diagnosed with MCTO as well. So you can see in the hand and wrist x-rays of the mother, they appear very abnormal. I provided the x-ray of a normal hand to the right of the slide for comparison purposes. And typically there are 8 carpal bones in the wrist joint. And in this patient at age 33 years old had none of the carpal bones present. She also demonstrates a penciling of the proximal metacarpals, which can frequently be seen in patients with MCTO. And this is also referred to as a sucked candy appearance of the proximal metacarpals. This patient also demonstrates pretty significant osteolytic changes of the distal radius and the distal ulna. When these patients with MCTO are examined clinically at the hands and their wrists, they can demonstrate this ulnarization of the wrist where the hand is deviated towards the ulnar side of the wrist. And at the metacarpophalangeal joint, which is at the base of the fingers, there's a hyperextension that can be seen. You can also sometimes appreciate a tapering and slender appearance to the distal ends of the phalanges. So there's also a proclivity for the tarsal bones, as can be seen in this 3-year-old child. The midfoot compartment appears hypoplastic and shortened. When you look at the corresponding x-ray, you can see that there's been osteolysis in that midfoot compartment of the foot. In the 12-year-old x-rays of the child below, you can notice remarkable osteopenia in the foot and ankle bones, and also pretty significant osteolysis of the tarsal bones. And in this patient, there is additional involvement of the calcaneus and the talus bones, whereas in the child above at age 3 years had relative preservation of the calcaneus and the talus bones. This 12-year-old child also demonstrates osteolytic changes at the distal tibia, as well as the distal fibula, and also the proximal metatarsals appear abnormal as well. So one can sort of imagine that with this degree of bone and joint deformities, that these patients can present with mobility challenges and abnormal joint function. And in this 12-year-old child, she was reported to be unable to walk, and she actually learned to walk on her knees as a child. And so this lack of weight bearing and ambulation status may have contributed to her osteopenia that's seen in the foot and ankle bones. Additional clinical component to this patient's presentation is that she was a late diagnosis to MCTO. She had presented with end-stage renal disease at the age of 12 years, and it was only thereafter that she was diagnosed with MCTO. So virtually all patients with MCTO will have osseous lesions of the wrist or ankle bones, but it's important to be aware that other bones and joints can be involved in MCTO. In a review paper of the 51 published cases, 97% were reported to have involvement of additional joints, most commonly that of the elbows, but the knees, the hip, and also scoliosis has been reported. When the elbow joint is impacted, this usually only becomes apparent after the wrists have become involved. And because of the progressive bone resorption that occurs in the elbow joint, this eventually leads to an elbow joint subluxation. And the reported average age for this complication to occur is around age 7 years. And so clinically, patients who have a pretty significant elbow involvement can have this sort of locked flexion position to the elbow, which obviously will impact the use and function of that joint and the affected extremity. So patients with MCTO will have renal involvement very frequently. In the same review paper of 51 cases, 2/3 of the patients were noted to have renal disease. The median age of renal involvement is the young age of 5.5 years. And 50% of those with renal disease will go on to develop renal failure. The renal involvement in MCTO can be pretty variable, but it's usually characterized by a fluctuating proteinuria. They can develop hypertension, and there's progressive impairment of renal function over time. The estimated time to progression from proteinuria to end-stage renal disease is estimated to be around 3 years, with a range of 0 to 13 years. So in the patients with MCTO that had undergone renal biopsies, the biopsies generally are consistent with FSGS or focal segmental glomerulosclerosis. And clinically, ACE inhibitors have been used to try and decrease the proteinuria, although it's not known whether this treatment reverses the underlying disease process. Interestingly, there was a patient reported in the literature that was treated with cyclosporin A, and this treatment was shown to reduce pretty significantly the urine albumin to creatinine concentration when they were on treatment. And interestingly, the patient underwent a follow-up renal biopsy after about 30 months of treatment. And they noted that there was not significant progression of the renal sclerosis. And so they considered the fact that the patient was cyclosporin A, and maybe that had slowed the progression of the renal sclerosis. So taken together, this slide really highlights the frequency of kidney involvement in patients with MCTO and the young age at which it can present. And so it highlights the importance of an early diagnosis and early screening for nephropathy so that patients are not presenting an acute renal failure as their initial presenting symptom of MCTO. So patients with MCTO can share certain craniofacial features. In the literature, a triangular face and micrognathia are frequently reported. Patients can have a maxillary hypoplasia that leads to the appearance of exophthalmos or protrusion of the eyes. For reasons that are unclear, several patients with MCTO have been reported to have corneal opacities. Patients with MCTO can have hypoplasia of the nares. They can have a chin dimple, interestingly enough, and they can have underdeveloped slit philtrum and a small mouth and a thin vermilion border. So when there's the presence of these craniofacial features, particularly in the context of arthritis or nephropathy, it's important to consider a diagnosis of MCTO. So while the clinical presentation among patients with MCTO can vary pretty widely, sometimes even within the same family, they do share a genetic homogeneity where all patients with MCTO harbor mutations in a very narrow region of the MAFB gene. To provide a little bit of background of MAFB, this is a basic leucine zipper transcription factor. It is a member of the large MAF subfamily. There is a transactivation domain close to the N terminus and towards the C terminal region. There is the leucine zipper structure that is responsible for subunit dimerization and binding of DNA to bind specific MAF recognition elements, otherwise called MERS. And MAFB can support gene transcription, activation, or repression, depending on the specific subunit that it dimerizes with. So in MCTO, the mutations are all dominant missense mutations, and they tend to cluster within a very narrow region of the transactivation domain of the MAFB gene. This table summarizes the 20 unique missense mutations that have been reported in the literature since 2012 in the less than 60 patients. You can see in this table that in this region of the MAFB gene where MCTO mutations occur, there's a richness of proline residues as well as serine residues and threonine. And so this represents a target site for protein phosphorylation. And this is an important mechanism to regulate MAF protein stability. There is experimental evidence to support that in MCTO monocytes and macrophages, there is a greater concentration of MAFB protein levels, and that there's extended half-life of the protein. And so this suggests that the MCTO mutations in MAFB confer an increased protein stability, as well as confer a gain of function type of property. Additional evidence that MCTO mutations may represent gain of function come from studies in Duane retraction syndrome. This is a congenital oculomotor disease characterized by impaired horizontal eye movements and FSGS. Patients with this condition also share mutations in the MAFB gene, but they occur in a different part of the gene. They occur closer to the C terminus, and these patients have loss of function mutations because of truncated MAF proteins that prevent DNA binding. Additionally, these patients with Duane retraction syndrome, they don't exhibit the osteolysis or the bone phenotype that is frequently seen in MCTO. So MAFB is expressed in diverse cell types. Relevant to MCTO is its expression in the developing kidney. MAFB has been shown to be essential for normal podocyte development as well as renal tubule survival. And in the MAFB homozygous mutant mouse, they demonstrate a renal hypoplasia and dysgenesis, as well as increased serum creatinine levels early on in life. And the histology demonstrates abnormal podocyte differentiation as well as tubular apoptosis. Similarly, in the MCTO mouse model that harbor a human MCTO mutation, the nephropathy that's seen in the mice resembles that of human patients. Specifically, they demonstrate high urine albumin to creatinine levels beginning at a young age, and their histology shows FSGS with a greater number of sclerotic glomeruli compared to wild type. So MAFB is also involved in hematopoiesis and is expressed specifically in the myeloid pathway. And so MAFB is known to induce myeloid differentiation towards monocytes and macrophages. And this is coupled with a strong inhibition towards erythroid commitment. And so when MAFB is overexpressed, this leads to a significant induction of monocytes and macrophages. MAFB has also been shown to regulate the differentiation of macrophages to osteoclasts, but here it's been shown to be a negative regulator of osteoclastogenesis. So in other words, MAFB inhibits osteoclast differentiation, and there needs to be a downregulation of MAFB expression in order for osteoclast differentiation to occur. And rank ligand stimulates this downregulation of MAFB. And when MAFB expression is downregulated, this then enables key factors like MIT-F and NFAT-C1 to drive transcription of OSCAR, which is important for osteoclast differentiation. So taken together, this relationship of MAFB as a negative regulator of osteoclast differentiation highlights a bit of a conundrum in MCTO that's challenging to reconcile, because presumed gain of function mutations in MAFB would lead to decreased osteoclastogenesis, whereas the skeletal phenotype in MCTO suggests that there's increased osteoclastic bone resorption. So what do we know about bone density and bone turnover in MCTO? There's very limited data available in the literature, but of the assessments that have been reported, bone density ascertained by DEXA in patients with MCTO seem to be normal to just slightly low. The lowest BMD-Z score at the spine is -1.4, and the lowest BMD-Z score at the hip is -1.1. It's important to acknowledge that there's just a few patients being considered in these reports, and also the DEXA assessments of the hip and spine are unlikely capturing the more significant regional osteopenia that can be seen in the peripheral skeleton. And so I'm only aware of one patient with MCTO having been reported in the literature having undergone a peripheral QCT assessment. And this is that of a 13-year-old boy who had demonstrated low total trabecular and cortical bone densities at the radius. And at the tibia, the total bone density and the cortical bone density was low. When the microtexture parameters are taken into consideration, it seems that the trabecular compartment seems to be more affected in the radius, and the cortical compartment seems to be more affected at the tibia. So this patient was also noted to have generalized high bone turnover. The serum CTX levels were reported to be elevated, as was the rank ligand to OPG ratio. And this patient had gone on to be treated with denosumab, and they reported a stabilization of the osteolysis. So with osteoclast-mediated osteolysis having been regarded as the primary mechanism underlying the bone phenotype in MCTO, it makes sense that patients had been treated with anti-resorptive agents. Unfortunately, though, the collective clinical experience with bisphosphonate therapy has been a bit disappointing. Since the treatment with bisphosphonate has not been shown to significantly alter the trajectory of the disease, and there seems to be ongoing destruction of the carpal and tarsal bones despite treatment with bisphosphonate therapy. It's certainly possible that the dose and the frequency of bisphosphonates have been insufficient, and it's understudied as to whether bisphosphonate treatment could be slowing down the rate of disease progression. But nonetheless, because of the disappointing historical experience with bisphosphonate therapy, some patients have been treated with denosumab. And in the few published case reports that had used denosumab, they report improved pain and joint function, as well as stabilization of osteolysis in one of the case reports. I think there may be a component of publication bias, since in discussion with other colleagues, they do anecdotally report a negative results with denosumab in their patients, and they mimic the clinical experience of that of bisphosphonates. In addition, some of the patients that were reported to have been treated with denosumab, they had experienced some side effects, and some had developed rebound hypercalcemia upon withdrawal of denosumab treatment. And so the safety and the efficacy of denosumab therapy still requires further study in patients with MCTO. But taken together, the lack of clear therapeutic effect of the anti-resorptive agents suggests that the pathogenesis of MCTO may be more complex than osteoclast-mediated bone destruction alone. And so this segues to a proposal to reappraise the pathogenesis in MCTO. So in this figure, the osteolysis bubble here is separated from the rest because this had been regarded historically as the primary mechanism underlying the phenotype in MCTO. But perhaps there's more to the story and there is more pathogenic mechanisms that should be considered. It's been suggested that perhaps there could be a component of chondrocytes or osteoblasts leading to dysfunctional bone formation. And it's uncertain as to what the role in inflammation might be in patients with MCTO. So with regard to the significance of inflammation in MCTO, as mentioned, this is uncertain and certainly more research is needed. But if one had to build a case for inflammation in MCTO, it's very curious that patients will frequently present with joint pain and swelling symptoms to the extent that they are diagnosed with JIA. Additionally, the patients that undergo additional imaging studies beyond plain x-rays have documented joint inflammation. So patients who have had MRIs, they demonstrate synovitis, tenosynovitis, and also joint effusions. There are positive reports of joint pain relief and improved joint function after starting anti-rheumatic treatments. And in the case study that'll be presented following conclusion of the didactic portion of this talk, there's a young child that had begun to weight bear and walk after initiating anti-rheumatic treatments. Additionally, that patient re-demonstrated joint pain and inflammation on imaging studies when the methotrexate treatment was withdrawn from her treatment plan. And finally, chronic inflammation of any cause is well known to promote osteoclast-mediated bone resorption. And so whether the inflammation is primary or secondary in MCTO, perhaps this aspect of the presentation should be taken into a clinical consideration. In the case against inflammation for MCTO, it's important to acknowledge that not all patients with MCTO will present with painful joint swelling or respond to anti-rheumatic treatments. When serological markers of inflammation are evaluated, very frequently they are normal or they're negative. A patient had undergone synovial biopsy and no inflammation was seen in that patient. And finally, but importantly, treatment for JIA with these anti-rheumatic treatments does not prevent the eventual progressive destruction of the carpal and tarsal bones. So dysfunctional ossification of the carpal tarsal bones instead of osteolysis may be a separate potential explanation for the phenotype in MCTO. And this can best be appreciated when reviewing the x-rays of younger patients. So in this patient who's age 3 years old, you can see in the right wrist that there is just one carpal bone, and in the left wrist there are only 2 carpal bones. And for comparison purposes, in the wrist of a patient without MCTO, there is up to 4 carpal bones undergoing ossification. In addition to having a reduced number of carpal bones, this patient with MCTO has carpal bones that appear smaller and dystrophic. The carpal bones are more stellate in appearance compared to the more rounded carpal bones in the patient without MCTO with smoother rounded borders. Certainly one can surmise that this patient with MCTO may simply have a delayed bone age and that the ossification centers will eventually develop over time. But an observation that perhaps competes with this expectation is that the risk compartment in the patient with MCTO is significantly narrower and smaller compared to the risk compartment of a patient without MCTO. And so this suggests that perhaps the cartilaginous template or preparation of that wrist joint is ill prepared for the eventual ossification of the carpal bones. And for comparison, the x-ray in the lower right here is that of a 1-year, 3-month-old child. And despite being younger, there's more significant room and space between the proximal metacarpals and the distal radius compared to the 3-year-old patient with MCTO. And there is some experimental evidence to support this notion of dysfunctional bone formation. For starters, MAFB is expressed in the growth plate chondrocytes. This is histology of a neonatal rat femur, where PZ represents the proliferative zone and HZ represents the hypertrophic zone. And MAFB staining localizes to both the proliferative and the hypertrophic zones. This group also demonstrated that MAFB regulates chondrocyte gene expression in chondrocytes that are undergoing differentiation. And under the stimulus of retinoic acid, which is known to promote terminal differentiation of chondrocytes, this leads to decreased gene expression of aggrecan and increased expression of MMP3 and MMP13, which are known to catalyze the degradation of aggrecan and collagen, leading to a decreased formation of extracellular matrix. So in a different set of experiments, MAFB expression was examined specifically in the forepaws of a normal murine model, recognizing that the bone destruction that's seen in MCTO occurs in a site-specific manner, primarily of the wrists and ankles. So first, this group demonstrated that the carpal bones, the distal ulna and radius, as well as the proximal metacarpals undergo a similar pattern of maturation. And beginning at age day 2, these wrist bones are predominantly composed of cartilage. By week 8, there's demonstration of mature bone in these wrist bones with a peripheral rim of articular cartilage surrounding all of the wrist bones in this forepaw. When they performed immunohistochemical staining, they demonstrated that MAFB was expressed in the carpal chondrocytes from the earliest stages of subarticular bone formation, and there was universally positive MAFB staining of the peripheral chondrocytes in the carpal bones. So these findings help us understand why perhaps in the risks of patients with MCTO that we don't see just involvement of the carpal bones, but also why we may see involvement of the proximal metacarpals. And also these findings support the notion that perhaps there could be dysfunctional chondrocyte and bone formation occurring in MCTO. So to wrap up the didactic portion of the presentation, these next 2 slides have some key take-home points. MCTO is a rare disease caused by missense mutations in the transactivation domain of MAFB. MAFB is characterized by progressive destruction of the carpotarsal bones, but other bones such as the elbow joints may be affected. Symptoms can mimic JIA, but one should consider a diagnosis of MCTO, particularly if arthritis symptoms are accompanied by nephropathy as well as craniofacial differences. It's important for early recognition and a genetic diagnosis of MCTO in order to inform proper counseling and management of these patients, and particularly for the early detection of renal involvement. Currently available treatments are very limited and generally supportive, and they've been ineffective to prevent disease progression. So with regard to pathophysiology of MCTO, this is not well understood. Osteolysis has been regarded as the primary mechanism, but the joint pain and swelling symptoms that accompany the initial presentation of these patients may suggest that inflammatory arthropathy is a characteristic of MCTO, or at least coexist with the condition. Dysfunctional endochondral bone formation may also partially explain the lack of effectiveness of the anti-resorptive agents to date. And clearly more research is needed to better understand the mechanistic pathways to inform better targeted therapies in the future. So I thank you for your attention. I'm happy to address any questions. These are my email addresses at the hospital and at the university in case anybody would like to reach out after this presentation. I do want to acknowledge Sophie's Neighborhood. This is a 501c3 devoted to building a community among patients and families with MCTO and also to stimulate research in this condition. And if anybody attending this session have patients with MCTO that may be interested in enrolling in a natural history study, this is a link to provide some contact information in order to connect us. Alternative, you can email me and connect us with the patient that way.
Terrific. Thank you so very, very much. Great presentation.